Good morning, one and all. At the outset, I'd first of all like to thank the organizing secretary for inviting me today. I'm going to present two papers. Till now, we were speaking about the difference in the radiation volumes or difference in the fractions, and now I'm going to present two papers which will probably talk about the omission of radiation. So the first paper was presented at the ASCO 2022 by Timothy et al. From Canada. It is about a prospective trial omitting radiotherapy following breast conservative surgery in T1N0 luminal A breast cancer. So with the background, we all know that adjuvant breast radiation following BCS is done because to reduce the local recurrence. However, sometimes it is inconvenient, costly, and associated with toxicities. There are traditional clinical pathological factors, but they are very limited in the factor that to identify which women would not be needing radiation. So we are trying to define more molecular but defined intrinsic subtypes of breast cancer, which can provide additional information that these patients have the tendency of low recurrence where we can avoid radiation. A retrospective analysis of a previous trial with women more than 60 years with luminal A grade 1 and 2 T1N0 breast carcinoma treated with BCS and endocrine therapy alone had a low rate of local relapse. This was been published in JCO 2015. So the utility of identifying luminal A subtype combined with CPF has not been prospectively evaluated for this ability to guide radiation decision making. And with this background, this prospective multi-center cohort study was performed. The eligibility criteria was women more than equal to 55 years. They have undergone BCS for grade 1 and 2 T1N0 MBC with more than 1 mm margins of excision, luminal A subtype, which was defined as ER more than equal to 1%, PR more than 20%, HER2 negative, and Ki67 is less than equal to 13.25%. This Ki67 was performed centrally in one of the 3 Canadian laboratories using the international Ki67 working group methods, whereas the ER, PR, and HER2 was performed according to the ASCO guidelines. These patients were treated with adjuvant endocrine therapy and not to receive radiation. The primary outcome was defined as local relapse, defined as time from the enrollment to any invasive or non-invasive cancer in the ipsilateral breast. The patients were followed up for every 6 months for the first 2 years and then yearly, and the probability of local relapse was estimated using the cumulative incidence function with death as a competing risk. The secondary outcomes were contralateral breast cancer, relapse-free survival, disease-free survival, secondary cancer or death, or overall survival. What the results were that this was a study which was from August 2013 to July 2017 with about 501 patients who were found to be suitable with a median follow-up of 5 years, the median age as 67, and about 88%, that is 442 patients were less than 75 years of age group. The median tumor size was 1.1 centimeter, and if we see in the table, the 5-year rate of local relapse satisfied the pre-specified boundary, that is about 2.3% of local relapse and about 1.9% of contralateral breast cancer. So this concludes that women as more than 55 years with grade 1 and 2 T1N0 luminal A breast cancer following BCS treated with endocrine therapy alone had very low rates of local relapse at 5 years and are candidates for omission of radiation. The second paper was presented at the San Antonio Breast Cancer Symposium. This is a validation of profile for the omission of local adjuvant radiotherapy. That is a POLAR study in a meta-analysis of 3 randomized controlled trials of breast conservative surgery plus or minus radiation therapy. The background remains the same that we have seen in the EB-CTCG meta-analysis that radiation recurrence reduces the recurrence in all subgroups, but there is a need for clinically validated and useful predictive biomarker for the radiation benefits. A signature for RT omission was developed and primarily validated with the SWI-BCG 91RT trial, but the validation in additional studies was needed. And this polar one, which is a 16-gene mRNA-based signature with the gene set themes, which includes immune response and proliferation, the scores were dichotomized to high versus low by applying a pre-specified cutout at the 25th percentile. The clinical validation of this polar signature, if we see from the 3 trials, that is the Sweden, Canada, and Scotland, with all patients about less than 5 or 4 centimeter tumor size with N0, performed BCS and given randomized between radiation to receive radiation, not to receive radiation. With the baseline demographics, if we see most of these patients were of the age group of 50 to 70 years, most of them were the luminal A subtype. And with this background, they performed a meta-analysis of these node-negative patients with ER positive and HER2, with all these 3 SWI-BCG 91RT, Princess Margaret, and Scottish conservation trials, assessing the performance of polar signature as a prognostic factor for local regional recurrence in the absence of radiation or as a predictor of benefit from radiation following the BCS. What they saw was that those patients who had a polar scores as low, the cumulative incidence of local regional recurrence did not matter whether the patient received radiation or not. But of course, for the patients who had a higher scores, the incidence of local regional recurrence was more if the patient did not receive radiation. Even on the platform of univariable or multivariate analysis, we saw that the polar scores had the hazard ratio of 1.53 on the univariable setup, and on the multivariate setup, it was 1.43 as a hazard ratio. So to summarize, the polar study in these 3 independent randomized trials yielded consistent results that patients who have a low polar score showed minimal benefit from radiation following BCS. This was confirmed in a patient-level meta-analysis combining all these 3 trials. The continuous polar score was also a significant prognostic factor in both the univariate and the multivariate, and the test for interaction between radiation and polar has a predictive classifier for benefit of radiation was positive with a p-value of 0.022. So to conclude, to this knowledge, polar becomes the first genomic classifier that is not only a prognosticator for the local relapse rate, but also a predictor for radiotherapy benefit, showing a significant interaction between radiation and the classifier. While the patients with a high score, they benefit from radiation, but those patients with a low polar score would not benefit from radiation and therefore can be a candidate for the omission of radiation after breast conservative surgery. These important respiratory findings warrant further investigation, including in contemporary clinical studies. Now to summarize, having studied these 2 abstracts and what I could go through from the literature was that today we are talking about de-escalation, de-intensification, but still the world data regarding the omission of radiation is still not consistent. If we see, we have a lot of contradictory papers. If we see the paper from 2020 by Ying Zhang from China with 500 plus patients, more than 70 years of age group, the disease-free survival of overall survival is same whether the patient receives radiation or not. But then you find a contradictory paper in 2019 by Goodwin et al., who says from the alternate retrospective data, with about 40,000 plus patients, after the exclusion criteria, 23,000 patients were eligible, they found that radiation is important. And a similar paper from 2015, Journal Clinical Oncology by Fifi et al., where the clinical subtype classification, that is luminal A with the ipsilateral breast relapse rate is 5.2%, luminal B is 10.5%, and the high-risk subtypes as 21.3%. We find that more because of this IHC subtyping, it can be a prognostic factor for assessing the ipsilateral relapse rate, but not predictive to whether the radiation would benefit or not. So that is why I think the Polar came out with the study of using Ki67, which is a marker. But today we stand with the same question, that do we really need Ki67, or there can be a better ways of predicting that. However, I think findings presented at all these medical meetings should be considered preliminary until it is published in a peer-reviewed journal. Thank you very much for your patient hearing.